Prescribing for older people is complex, particularly in the presence of multimorbidity. Ensuring the appropriate balance of prescribed medicines requires a consideration of pharmacokinetic and pharmacodynamics parameters, a knowledge of the potential adverse effects as well as the potential for inappropriate prescribing. Adopting a systematic approach to ensure that patients receive the maximum benefit from their prescribed treatment is essential. While various approaches can be used, it is important that the approach undertaken is tailored to individual patient needs and what is achievable within the clinical practice setting. Next, we will discuss the aging population. Globally, the population is aging, with the proportion of people over 60 years of age set to increase from a current estimate of 962 million to a projected 2.1 billion by 2050. The relative proportion of people aged over 60 years is also projected to rise, and will reach 1 in 5 by 2050. On a European level, currently, 24% of the population is aged 60 years or over, a figure projected to increase to 34% by 2050. The oldest old cohort, i.e., those aged 85 years and older, is also aging. Globally, it is estimated that 14% of people are in this cohort, the proportion of which is expected to increase to 19% by 2050. Consequently, there will also be an increase in the prevalence of disability, as more older people suffer from disability when compared to a younger population. The prevalence of disability among persons under 18 years is 5.8%. This prevalence increases to 44.6% among 65 to 74-year-olds, and increases further to 84.2% in those aged 85 years and over. Drivers of this demographic shift include the improved provision of healthcare services, advancements in diagnoses and treatments of conditions, advancements in public health strategies, improved nutrition and sanitation, an increase in life expectancy, and a decline in birth rates as well as migration. In response to this demographic shift, the World Health Organization, WHO, recently launched a global strategy and action plan on aging and health, whose vision is to ensure a world in which everyone can live a long and healthy life. There are 5 key strategic objectives linked to achieving this vision, which include the following. 1. Commitment to action on healthy aging in every country. 2. Developing age-friendly environments. 3. Aligning health systems to the needs of older populations. 4. Developing sustainable and equitable systems for providing long-term care. And 5. Improving measurement, monitoring and research on healthy aging. The practice of pharmacy and the provision of pharmaceutical care services play an important role within each of these objectives, and hence the implications for the pharmacy profession within this vision are significant. Understanding the aging process and mechanisms by which prescribed therapy can be optimized will help realize the WHO's vision of enabling older people to live a healthy and long life. Next, we will discuss chronic conditions and multimorbidity. The prevalence of all chronic conditions and the presence of multimorbidity, the coexistence of 2 or more long-term health conditions, increase with age. Current estimates suggest that by the age of 65 years, over 60% of adults will have 2 or more chronic conditions, greater than 25% will have 4 or more, while 10% will have 6 or more chronic conditions. Cardiovascular disease is the leading cause of morbidity and mortality in older people, and is associated with significant multimorbidity. Over 50% of patients who have heart failure or stroke also have at least 5 comorbid conditions. The most common concomitant conditions in patients with heart failure, stroke, or atrial fibrillation are arthritis, anemia and diabetes mellitus, with chronic kidney disease, chronic obstructive pulmonary disease, depression and cognitive impairment also being common. The prevalence of cognitive impairment, Alzheimer's disease and other dementias is low at younger ages, and nearly doubles with every 5 years of age after the age of 65. It is estimated that 25 to 30% of the population aged 85 years or older have dementia. Patients with Alzheimer's disease are more at risk of medication errors than those without, which may in some cases be due to non-adherence or indeed over-adherence. In general, the occurrence of multimorbidity also leads to the prescribing of polypharmacy, Section X. Because the majority of evidence-based guidelines are written for single diseases, knowledge and understanding of how medicines are handled in the body with increasing age is fundamental to the provision of pharmaceutical care for older people. Next we will discuss pharmacokinetics and pharmacodynamics. Physiological changes that occur heterogeneically with aging affect the body's handling of medicines, i.e., pharmacokinetics, and its response to medicines, i.e., pharmacodynamics, to varying extents. These changes result from the loss of functional capacity of several organs as well as the reduced efficacy of homeostatic mechanisms. We will now discuss pharmacokinetics. Pharmacokinetics involves 4 components: absorption, distribution, metabolism, and elimination. Knowledge of each of these parameters is important to ensure the appropriate design of patients' medication regimens, to ensure efficacy and to prevent toxicity. The clinical implications for each of these vary, and certain drug properties need to be considered when predicting the extent to which each individual drug is affected. Table 26.1 summarizes the key physiological changes that affect each pharmacokinetic parameter, the impact these changes have on each parameter, and some examples of their clinical significance. We will now discuss pharmacodynamics. Pharmacodynamics refers to the change in the response to drugs with time. Pharmacodynamic changes that occur with aging may result from organ system changes, alterations in homeostatic functions, or from receptor and cellular changes. Table 26.2 provides a summary of commonly occurring pharmacodynamic changes associated with aging. Pause the video and carefully scrutinize Table 26.1 summarizing age-related changes in pharmacokinetics before advancing to the next slide. Pause the video and carefully scrutinize Table 26.1 summarizing age-related changes in pharmacokinetics before advancing to the next slide. Next we will discuss pharmacokinetics and pharmacodynamics in practice. The application of the known potential pharmacokinetic and pharmacodynamic changes that occur with increasing age facilitates the prediction of therapeutic outcomes, and consequently the occurrence of adverse events may be avoided. Table 26.3 provides some examples. Pause the video and carefully scrutinize Table 26.2 summarizing pharmacodynamic changes associated with aging before advancing to the next slide. Pause the video and carefully scrutinize Table 26.3 summarizing the application of pharmacokinetic and pharmacodynamic changes to commonly encountered medicines in older adults before advancing to the next slide. Next we will discuss prescribing for older people. Let's begin with polypharmacy. Predicting the pharmacokinetic and pharmacodynamic effects of medicines is more challenging when several medicines are prescribed. To that end, polypharmacy describes the prescribing of multiple medicines and has been noted as one of the most pressing prescribing challenges. Despite the fact that the term polypharmacy is widely used in the literature, there is a lack of consistency with how polypharmacy is defined. Polypharmacy is commonly assigned a numerical value of 4 or 5 concomitant medicines, but has also been viewed historically in a negative light, i.e., the prescribing of too many medicines, or the prescribing of more medicines than are clinically indicated. However, due to the growing prevalence of multimorbidity, Section 7.2, the enhanced availability of primary and secondary preventative treatments and evidence-based guidelines that advocate for the prescribing of multiple medicines, the prescribing of many medicines may be entirely appropriate, indicated and necessary in order to maximize patient outcomes. This transition in thinking, or paradigm shift, as shown in Figure 26.1, has led to the adoption of the term appropriate polypharmacy, which provides for the prescribing of several medicines, where medicine use has been optimized and prescribing is in accordance with best evidence. In essence, this recognizes that the prescribing of several medicines is often required, and ensuring that these medicines are optimized is imperative to achieve appropriate polypharmacy. Polypharmacy has often been viewed in a negative light because the use of several medicines can lead to medication-related problems such as adverse drug reactions, Section 26.4.2, potentially inappropriate prescribing, Section 26.4.3, and poor patient adherence, Chapter 5. Next we will discuss adverse drugs reactions. The risk of the occurrence of an adverse drug reaction, abbreviated as ADR, defined as any response to a drug which is noxious and unintended and which occurs at doses normally used in human beings for diagnosis, prophylaxis or therapy of disease and excluding a failure to accomplish the intended purpose, increases with age, owing to pharmacokinetic and pharmacodynamics changes described above. 26.2, Polypharmacy, 26.4.1, Multimorbidity, Section 26.3, Inappropriate prescribing and monitoring. The most commonly occurring adverse drugs reactions in the older population include renal failure, orthostatic hypotension, falls, delirium, gastrointestinal and intracranial bleeding, and the most commonly associated medicines with adverse drugs reactions-related hospital admissions include diuretics, non-steroidal anti-inflammatory drug, antiplatelets, anticoagulants, anti-diabetics, and medicines with sedative properties. Many adverse drugs reactions are preventable by adopting strategies such as minimizing inappropriate prescribing and unnecessary polypharmacy by undertaking regular medication review, considering the potential risk-benefit ratio of treatment, using the minimal effective dose of medicines and limiting the number of medicines prescribed. Next we will discuss potentially inappropriate prescribing. Potentially inappropriate prescribing, abbreviated as PIP, encompasses a set of prescribing practices, where the risk of prescribing a particular medicine outweighs the potential benefits to the patient, and includes 1. Overuse, 2. Misuse and 3. Underuse of medicines. The word potentially is used as, without engaging with the prescriber, it is not possible to determine if, in fact, the prescriber had considered the risk or risks associated with prescribing the particular medicine, possible alternatives to that medicine and their associated risk or risks, or the individual patient's preferences. Considering these factors, it is possible that the prescriber made an informed decision to continue the particular medicine in question. The overuse of a medicine results from the prescribing of a medicine at a dose, frequency or duration that exceeds evidence-based recommendations. For example, The use of digoxin at a long-term dose of greater than 125 micrograms when renal impairment is present, or the use of long-acting benzodiazepines or benzodiazepines with long-acting metabolites for a long term, i.e., longer than 1 month. The misuse of a medicine involves the prescribing of a particular medicine that has certain associated risks, whereby there is a safer, more effective alternative available. For example, the use of selective serotonin reuptake inhibitors in patients with a history of clinically significant hyponatremia, or the use of theophylline as monotherapy for patients with chronic obstructive pulmonary disease. The underuse of medicines occurs when a medicine that is clinically indicated for either primary or secondary prevention is not prescribed, and there is no apparent contraindication to that medicine. Examples include the omission of calcium and vitamin D supplementation in patients with known osteoporosis, or the omission of folic acid supplementation in patients taking methotrexate. In comparison to other components of inappropriate prescribing, i.e., overuse and misuse, underuse of medicines is poorly understood. Next we will discuss strategies to enhance prescribing for older patients. Various initiatives are recommended to ensure that patients' medicines are prescribed appropriately in order for patients to get the maximum benefit from their prescribed treatments with minimum risk of adverse events. These include Medicines Reconciliation and Medication Review, Chapter 7, Section 26.5.1, Medicines Optimization, Section 26.5.2, and using screening tools within a review, Section 26.5.3. Guidance on improving prescribing for multi-morbid patients has also been recently published by the National Institute for Health and Care Excellence, NICE. We will now discuss medication review in older people. One medication review strategy specifically designed to target prescribing of polypharmacy for multi-morbid patients has recently been published by the Scottish Government. This guidance recognizes that necessary polypharmacy is a feature of modern therapeutics, and suggests adopting a 7-step approach to medication review. These steps involve establishing the aim, need, effectiveness, safety, cost-effectiveness and the patient's adherence to each medicine prescribed, as shown in Table 26.4. Evaluation of the impact and clinical implications of this guidance has not yet been reported. Pause the video and carefully scrutinize Figure 26.1 illustrating defining polypharmacy before advancing to the next slide. Pause the video and carefully scrutinize Table 26.4 summarizing the 7-step approach to medication review before advancing to the next slide. Pause the video and carefully scrutinize Table 26.4 summarizing the 7-step approach to medication review before advancing to the next slide. Next we will look at medicines optimization. Medicines optimization is another, similar concept to a medication review, aimed at maximizing patient benefit from prescribed treatments and is defined as a person-centered approach to safe and effective medication use, to ensure people obtain the best possible outcomes from their medicines. The Royal Pharmaceutical Society in the United Kingdom, UK, produced guidance on how pharmacists should approach the process of medicines optimization, and suggests the following 4 principles should be followed. 1. Aim to understand the patient's experience. 2. Ensure medicine choices are evidence-based. 3. Ensure medicine's use is as safe as possible and 4. Make medicines optimization part of routine practice. In contrast to a medication review, patients must be present as part of a medicines optimization consultation. The long-term clinical implications of adopting this process have not been reported. Next we will discuss screening tools. The use of screening tools to help facilitate the undertaking of a medication review is becoming increasingly popular, due to its positive effects on patient outcomes. Screening tools contain either explicit, rule-based or specific statements of inappropriateness, or implicit, judgment-based, criteria or a combination of both. And there are a variety of each type used in various clinical settings. Examples of screening tools include the FORTA, Fit for the Aged, list, Stop-Start, screening tool of older persons. Prescriptions or screening tool to alert doctors to right treatment, Priscus, and the Medication Appropriateness Index and LaRoche's list. The majority of these criteria were developed using expert consensus methodologies and are based on robust evidence. They vary in length, the countries in which they were developed, various aspects of potentially inappropriate prescribing targeted, e.g., the START component of the Stop-Start tool lists potential prescribing omissions, by the criteria and the clinical setting for which they were designed. Selecting the most appropriate criteria for use is important, and some time should be spent researching various options. Some of the key considerations are summarized in Table 26.5. While these factors should be considered, it is also important to bear in mind that each screening tool can be tailored or modified to reflect local prescribing practices and priorities. Once a screening tool has been chosen, there are other key factors that should be considered to ensure the maximum benefit from the screening tool within specific areas of practice. These include the patient information available, individual pharmacists' rapport with prescribers, prescribers' preferences and resources available. These are summarized, as shown in Table 26.6. This information has been compiled from a combination of reports from clinical practice and from research studies. Pause the video and carefully scrutinize Table 26.5 summarizing factors to consider when selecting a screening tool to facilitate a medication review before advancing to the next slide. Next we will discuss managing multi-morbidity. As noted previously, Section 26.2, the prevalence of multi-morbidity increases with age. The NICE in the United Kingdom, UK, has recently published guidance on how healthcare professionals should manage multi-morbid patients, as shown in Table 26.7. Their recommendations are summarized under the 5 main headings below. 1. Discuss the purpose of an approach to care that accounts for multi-morbidity. 2. Establish disease and treatment burden. 3. Establish patients' goals, values and priorities. 4. Review medicines and other treatments taking into account evidence of likely benefits and harms for the individual patient and outcomes important to the person. 5. Agree an individualized management plan with the patient. In essence, the process of managing multi-morbidity in older patients as recommended by NICE encompasses many of the principles of medication review, medications optimization and the use of screening tools, already discussed in the sections above. Pause the video and carefully scrutinize Table 26.6 summarizing challenges of using screening tools in everyday practice before advancing to the next slide. Pause the video and carefully scrutinize Table 26.6 summarizing challenges of using screening tools in everyday practice before advancing to the next slide. Pause the video and carefully scrutinize Table 26.7 summarizing mediation review for multi-morbid patients before advancing to the next slide. Thank you.